if it's okay with Mike, I'm going to start a bit of an opening question with him. So alongside your work as a professor of anaesthetics, and obviously being the co-founder for the Altitude Space and Extreme Environment Medicine CASE and Extreme Everest Oxygen Research Consortium, could you tell us a bit more about your research and what kind of inspired you to start work on these projects?
Thank you, Josie. So my research focuses, all of it focuses on either perioperative care, so the care of patients undergoing major surgery, or on critical care. And my clinical background was a long time ago internal medicine, but my main training was in anaesthesia and critical care. And in fact, my clinical day job these days is exclusively adult intensive care medicine. But most of my time is spent doing research. And I was, I guess, lucky enough about nearly 20 years ago, let's say 15, to manage to combine what was then my recreational interest with my professional interests, in that when I was at St George's, I'd started climbing a lot. I mean, I climbed a bit as a kid, but started climbing and traveling in the days when it was easy to just go away for the weekend to the Alps, for example, which I hope it will be again. And got into high altitude climbing through a couple of career breaks, including one immediately after house jobs. And in parallel, my professional career was developing down anaesthesia critical care. And I guess the intriguing thing was that all the physiology was just the same. The physiology seemed to be all about oxygen and the circulation in the lungs and oxygen transport. And as we subsequently discovered, actually oxygen metabolism. And gradually the two converged, and I was lucky enough to do my first research expedition in 2003, and then we'd already formed this centre with the academic aim of exploring the links or the things that you can learn from extreme environments, extreme physiology, and bring back to patients. And the Everest project really grew out of that, and that effectively dominated about the next 5 years of my life.
It's fantastic that you could marry your interest at the time. It makes me think about what I can do kind of with my own interest in certain societies. I wonder how I can take drama forward as a doctor. So
there's always a way.
You spoke a bit about the Extreme Everest team. So I know that they conducted research on themselves to help understand the effects of low oxygen on the body's working. What were some of the challenges of these conditions for you and your team when you went up there?
Yeah, interesting question. I guess the challenges were, say, the straightforward personal challenges of climbing altitude and being able to withstand the environment. But in a way, we made that as easy as we could for ourselves. We were lucky enough to be well funded because of the broader project, and we were very because of an emphasis on safety overall, because you can't really go and do a medical research expedition with the aim of improving care for patients and harm people in the process. We were pretty strict in a way that maybe some climbing trips aren't, about safety protocols. So everybody climbed in a buddy pair. We had very detailed protocols for turning back at different stages of the mountain, even to the extreme that on the summit day. Although I was the expedition leader, there was a clear authority given to the base camp manager to turn us around if in their view we were not behaving rationally, because we know that at extreme altitude the brain may not function as well as it might. So some of the challenges were around those kind of the climbing situations, but Everest is not actually the greatest climbing challenge. I think the bigger challenges were around the logistics of doing science on a glacier at 5,000 meters and setting up, for example, 240 volt AC and making sure it was safe, getting all our computers and equipment working. And I mean, I don't know if Bryony's comments will reflect the same, but preparation is everything. So we spent about 2 years ensuring that all our kit worked and measured in a valid way, and you could use it all together in all sorts of different environments. So we ran 3 separate expeditions beforehand, and in the same way we tested the people. So we were doing research up to over 8,000 meters before we went to Everest, so that as much as we could go there with a high degree of confidence that we'd be able to do at least most of what we'd set out to do. So the expedition itself was quite was hard work, and physically and psychologically, but I think that it is all in the preparation. So it was the 2 or 3 years beforehand that made it a success.
It definitely does sound like a lot of hard work went into this. So working on case like the Altitude Space and Extreme Environment Centre and the expedition, what has been the most rewarding thing about doing this sort of work?
I would say, so for me, and the same is true, frankly, in my clinical job and in my research job, which is sort of research leader's job, it's all about the people, and the greatest pleasures, the most special moments come from the people around you, and frankly also some of the most difficult bits come from some of the people interactions, which is not to say it's somebody else's fault, but it's just people sometimes struggle with each other. So I think the thing that the most rewarding thing, I think, is looking back on a project that I'm pretty confident I'll never experience anything like of again, which is working really closely with a team of really smart people who had a shared goal, and everybody had their individual tasks, but essentially worked towards that shared goal, and accepted that individual glory may or may not come, but the project was really high value, and it was a very special time, and we remain in contact. In fact, some of the team members managed to marry each other, and many others remain extremely close to each other. So it remains a community more than 20 years later.
That's wonderful to hear about your experiences such as that. So as a student myself, what sort of advice would you give to me if I wanted to go down like an anaesthetics pathway or extreme medicine as well?
Number one, you've got to love what you do. I don't think you can really engage over and above the 9 to 5 unless you've got a real passion for it. So I mean, I'd intended to be, having done an elective in Uganda, I'd intended to be an infectious diseases doctor and save the world through vaccination and that kind of thing. And frankly, I at George's, I enjoyed acute medicine so much, I just decided I want to do intensive care, and I went the anaesthetic route to do that. And I think in many respects it's a selfish decision, because I still think it's a smart thing to save the world through vaccination. But that's just the aspect of medicine that I loved. And some people love, the cut and thrust of general practice. Some people love the emergency department. Some people love psychiatry. And it's just you got to do something you love, and you've got to do it with people that the choosing your colleagues is a very important part of having a happy and successful career. So when you look at a department to go and work in, look at the people and look at the dynamic between them, because you don't want to work in an unhappy place or with people that you don't feel comfortable with.
Thank you very much, Mike. That's interesting advice to take forward. So I know that you've also done some additional work about helping lead the national guidelines for COVID-19, particularly in critically ill adult patients, and involving public health messaging at the start of the pandemic yourself, as your role of Vice President at the Royal College of Anaesthesists. What helped you kind of adapt to the ever-changing situation of COVID when building these guidelines?
That's an intriguing question. I mean, I ended up in that situation as many people did because of the position that I happened to have at the Royal College at that time. I guess interestingly, the Everest stuff, which had involved a lot of media interaction, was helpful in that it didn't feel, I wasn't particularly nervous of doing some of the media appearances, and in many respects they just, the messaging seemed so important. I'd say that wasn't particularly challenging. I think the biggest challenging was probably very similar to most people, which is with the complete uprooting of normal life, being on resident on-call rotas again, all those kind of things, worrying about older relatives who may or may not make it through, were very lonely, rather than the professional bits. The professional bits in some ways are the easiest, because you know how to do your clinical job, and I've done research and guidelines type work for years, so that feels quite, you know how to do that. There's a standard recipe. You have to pull the evidence together, you have to get the right people, you produce the guidelines, and you do the best you can, and it was in some ways easier to do that because there wasn't much else to do at the time. most people, I think, in certainly senior medics, were completely all in any acute specialty respiratory critical care on dealing with COVID. So that clearly felt like the right thing to do, and there certainly wasn't a holiday to go on or anything else to do. So I think COVID's, and I'm sort of not answering the question you asked, but forgive me. I think COVID's become more challenging as it's become more strung out, and actually it's now when particularly some of our nurses who've been working flat out for 18 months, had very few holidays. They've had colleagues get ill. They've had colleagues have to resign and retire, and I think now's the really difficult bit. I think as humans, most of us are quite good at responding to it, the short-term challenge and rising to that. It's when it becomes persistent and you don't get your usual fix of time off and everything else that it becomes harder. So I think now's the bit where we really need to look after each other and make sure we get through to the other side.
Thank you very much. It's a very genuine answer about your experiences of COVID. As a final question, just from my own perspective as a student, what do you feel like you've learned or gained as a healthcare professional going through COVID and treating patients at this time?
It's a relatively personal reflection, but our consultant group, there's 15 of us, or there was at the beginning of COVID, and by the end of it we had 25 because we've made new recruits and persuaded other people to join us. And I had only worked in Southampton for about 12 years when COVID started, which is a reasonable length of time, but lots of people in Southampton have been there for 30, 40 years. So I felt close to them and I knew them all as friends, but I actually didn't realise what a good team we were. And we met the challenge of COVID as a team. We had a brand new clinical director who did a brilliant job. He'd been part of the team for years, but had only just stepped up to that role. And I think we came out of it much more bonded. And I'm a bit like families. We probably used to bicker quite a lot beforehand. We're a lot better at not bickering now because we've been through that shared challenge. And that's probably one of the best professional bits that's come out of it.
Thank you very much for answering my questions so honestly and nicely like that. Thank you, Mike. If you do have any questions for Mike, please leave them to the Q&A at the end. I'm now going to pass on asking questions to Captain Hastings. Bryony, if you'd like to switch on your camera. Thank you.
Hi.
So first question for you, which I think everyone's quite interested in. What first made you want to explore the army as a career as a doctor?
So I was working after my physics degree. I started working in London at Sky Television because I didn't really know what I wanted to do. Got into volunteering, applied for medicine, and then in the first year of my course, I was living in London. All my friends were continuing their careers and getting promoted and getting pay rises, and I'd gone back down to sort of nothing. And a friend said to me, "Oh, the military do sponsorships. You should look into that." So I went to Sandhurst, which is where the officers do their training, to an acquaint visit, which was 2 days, and met the recruiting team, and they basically told me all of the opportunities that were available as a doctor in the army. And I left that thinking, I have to do this. This sounds incredible. The chance to be sort of very independent as quite a junior doctor, to travel, to do adventurous training. So I applied and it just went from there, really.
It sounds like there are so many opportunities that looking outside of the NHS can really bring you, especially the army. So in the introduction, we mentioned your deployment as a general medical officer for exercise Clockwork, which was an annual tri-service exercise with the Joint Helicopter Command within the Arctic Circle. So could you talk about what was most challenging and rewarding about working on an expedition like this, so unique?
So yes, as you said, we're 300 miles inside the Arctic Circle. It's an annual training exercise. So every year the tri-service helicopter pilots go out there to practice flying in arduous conditions. So in order to be allowed to be deployed to the base in Norway, everybody from the chefs to the doctor to the engineers, the pilots, all have to do a cold weather survival course, which is 10 days 4 of which are spent in the field and 3 nights in the field. I would say that was probably the most challenging bit from a personal sort of physical perspective, because as you can imagine, it was very cold, sometimes sort of minus 30 degrees. We did the first night in a 10-man tent, second night in a 4-man tent. The final night was a survival night. So they took all of our kit and equipment off us. We had to, I think we were given like a tin of potatoes, and that's all we had to survive with all night. So we had to build shelters and light fires and keep each other warm, which, as Mike was talking about, that sense of teamwork and camaraderie, you really test each other and sort of push yourselves, and you learn how to get on with people in those situations. And then the final day is you jump into, they cut a hole in a frozen lake, and the final part of the most challenging part is you have to run with your full kit on, full Bergen and ski poles. You jump into the lake through this hole. You've then got to pull yourself, swim to the edge, which you get. The idea is that you experience cold water shock, so that if you ever did fall in, you would know what is happening, and you know that you need to relax, swim to where you fell in from. You put your poles in the side, and then the sergeant who's run the course comes and asks you a few questions. When he's satisfied you've answered enough questions and you're in enough of a state, you've got to pull yourself out, roll in the snow. Then you run across the ice to, they build an ice bar where the commanding officer stands, and he's got a bottle of rum because he was in the Navy, and you've got to salute him and you say, "Hello, sir," and he gives you a shot of rum, you toast the Queen, and then you run and get changed, and that's like the culmination of the cold weather survival training. So that was kind of the fun bit. Challenging bits, I think when Mike was talking then about challenges of working at high altitude and in extremes, simple things that I had to think about as a doctor were things like, how do you keep your IV fluids as fluids when you're at temperatures of minus 30? How do you know that your defib is going to work if it's been outside in the cold? Things like, people wear a lot of layers, so if someone gets injured, you've got to sort of weigh up the balance of taking all the layers off and possibly giving them hypothermia with actually looking and seeing what's going on. And also, one of the main things they teach you on this cold weather course is to keep your hands warm. So as a doctor or as a medic treating somebody, you're the one who's sort of exposing your hands, and trying to treat someone with very cold hands is quite difficult.
It sounds like particularly your background in core science at physics might have helped with some of those interesting problems about like, for example, the IV fluid. Thank you for explaining the process.
It really didn't. But you just learn to improvise quite a lot. Yeah.
Thank you very much, Bryony. So what helped you prepare for some of your deployments overseas, particularly if you did know that you were working in extreme conditions? Was there anything that you did, maybe mentally or physically?
Physically, I tried to get as strong and fit as I could. I did a lot of hill running, a lot of training. From a professional perspective, I went to a clinic. In the military, we have special clinics for non-freezing cold injuries. And for people who've suffered sort of numbness, changes in the hands because of the cold, because that was something I had to be very aware of, not just in some ways because people who are out in Norway don't want to go home, so if they do get an injury they probably won't mention it or tell you, but also because for the military it's quite a big problem, because a lot of people get these non-freezing cold injuries and then they can actually sue the military. So there were sort of two main reasons: the sort of patient welfare and then also the sort of legal bigger picture that I had to think about. And I also did a military aviation course because pilots are very, I don't know if there are any in the audience, but they're very precious creatures, and they have a completely different set of rules to normal soldiers. So for example, they can't fly if they've got any symptoms of cold or flu, or if they're taking any medications, well, certain medications, if they haven't had enough sleep. So it's much more rigorous for pilots. So I went through a special course to learn more about pilots. And as part of that course, we had to experience G-force for ourselves. So they put us, it was at the RAF base in Henlow, so it put us on a centrifuge so we could feel G-force and see if we could fight G-force. So if ever, I mean, there weren't fast jets in Norway, but if ever we were working with fast jet pilots, we could explain to them what they needed to do to not pass out. So that was quite funny. We did hypoxia training as well to see how it feels to have sort of 60% oxygen levels.
I'm sure Mike can
60%.
exactly how that feels as well. Something that you share as a commonality. And my last two questions, something that I'm really interested in, particularly asking you as a fellow JEP, which is a graduate entry program. Would you recommend graduate medicine as a career change, and would you recommend studying in your 30s?
Yes, I would definitely recommend it. For me, it's just been brilliant. Again, as Mike was talking about the sort of teamwork that he really appreciated during COVID, I really found I had that on the JEP course. I felt I had a really good group, and we all bonded over PBL, over preparing for OSCEs, and it was really a shared challenge of getting and achieving your ambition of becoming a doctor. So yeah, I would definitely recommend it because I think it's brilliant. And I've worked with a lot of medics who are sort of the equivalent of healthcare support workers or healthcare assistants, but in the military, and a lot of military nurses, and I'm constantly encouraging them to think about graduate medicine. So yeah, I would recommend it to anyone. I was in my 20s when I did the course, and now I'd say, now I've started psychiatry training, I can definitely see that I have more experience and a wider breadth of experience that I can draw on in my work on the psychiatry wards, which I think is an advantage and probably helps my patients as well. But up until I started core training for psychiatry, which was 5 weeks ago, I would say the undergraduates and the graduates were very much on the same level. I didn't really see much of a difference in terms of maturity or experience.
Thank you very much, Bryony, for answering in that sort of candid way. I definitely agree with that. The confidence that comes with being on the wards, being slightly older and having previously studied is immense in speaking to patients and their families. I think that kind of maturity is very important to have. Thank you. And lastly, how do you think your time on the JEP course helped you prepare for your current career? Besides teamwork, any extreme conditions that George has put you through particularly?
You know what, the thing that I think about all the time is the Breaking Bad News session that I did at St Heliers Hospital. I don't know, have you done that yet?
I think I've got it later on this year to look forward to.
Yeah, and that always sticks with me because you use that so much of the time as a doctor and speaking to patients and almost building patients up to deliver some news that they might not want to hear. So I think that was a really great one. And then of course the teachers, lecturers, I think they were very inspiring, and I just used to love how they'd come off from the operating theatre down into the lecture hall, still in the scrubs. They're probably not allowed to do that anymore, but I just used to think that was brilliant, and you just thought, wow, I'm really getting sort of hot off the press sort of training here. So I really like that.
Okay, thank you very much. That completes my questions. Thank you very much for everyone listening to this part of the interview, and I'll hand back over to Heather.
Thank you so much again, Josie, Captain Hastings and Professor Grocott. That was really insightful. It was great to hear a bit more about your journey from St George's to where you are now. So I'm going to open it up to the audience if they'd like to ask questions. So I'd encourage you to ask questions to Captain Hastings, Professor Grocott and Josie about her own experiences as well on the graduate entry medicine course. So I'll just give everyone a couple of minutes and see if we've got any hands. Yeah, so got a question from Hannah Cock.
Hi, thanks both. I'll save my main thanks to the end, as I've been instructed to. But I mean, I really enjoyed that from all three of you. I'm slightly anxious about the idea that you have to have a special training course to learn to cope with pilots, and I won't tell my best friend who's married to one. And also the idea that we're, you know, the sort of stresses we put you through are you know, suitable training for the sort of environments that you've both experienced, which are clearly quite extreme. My question though really was, as you know, we take a mix of arts and science graduates on the programme, particularly the graduate, specifically the graduate entry programme. Now that you're sort of distant from it, I wonder if you can remember how aware you were of that at the time with your cohort. You know, how much of a sort of issue was it that, and how quickly did that all just become immaterial? And you know, what were the sort of pros and cons of that from a student perspective? Either of you.
Well, I do remember, and I imagine it's exactly the same now. But everyone used to say the people who hadn't done sciences just worked extra hard and actually knew the stuff in more detail than the people who kind of had done it at some point and just refreshed a bit of knowledge that they could vaguely scrape together. So I found academically there was no difference. Otherwise, it just added to the sort of variety of things that I got involved with, like the choir and the sort of, you know, the more arty side of life.
So again, it's harder for me to answer the question because I wasn't graduate entry. It only just sort of came along pretty much after I left. And then, in fact, I address this question most frequently now talking to other people who want to send their children to medical school and are saying, what O levels and A levels should they do? And my wife's also a doctor, and we both, despite doing quite a lot of research in metabolism amongst other things, can't understand why 3 science is essential. So I do get that some science and probably biology makes sense, because otherwise it's harder to know if you are going to like some of the aspects of study. But as a personal view, I'd be far more interested in people who have a greater breadth of interests at that point and experience an intellectual challenge, because as Bryony says, I mean, you've got to learn it all on the course anyway, and it's a particularly focused, you know, specific set of knowledge. So I'd be in favour of being much less strict, and you know, teaching things like economics might be a very good idea to some doctors.
I also think, yeah, I mean, I haven't used the Krebs cycle yet, but I also think teaching things like mindfulness, managing stress, work-life balance is something that I had a much better grasp of during graduate entry medicine than I ever did as an undergraduate. So I don't know if that's something that's part of the course.
It is actually. I mean, that's so. I mean, a lot of things have changed, I think. So forgive me, Mike. My maths isn't very good, so I hadn't quite worked out that was before graduates started. But I mean, the other thing that's changed in the last 10 years or so is that the graduate streams and the undergraduate streams completely merge now for the last 3 years of the course. So they're not separate at all. It's only the clinical science bit that's separate. So our 5-year stream students, the A-level students, actually all get mixed up as well with the graduates from for the last 3 years, which again I think we did for all the reasons that you're saying. It actually really adds to the richness and variety for everyone, and everyone's got their own strengths. And I mean, requirements of the GMC, tomorrow's doctors, have changed, you know, and the requirements of being a doctor have changed. And, you know, I qualified a few years ahead of Mike, not that many years ahead, actually. And so we'll both have seen that through our lives, how what you need to know now as a doctor is so different from what he or I would have covered at medical school. And so things like resilience and mindfulness and well-being and work-life balance and organizational skills and all that sort of hidden curriculum stuff is much more embedded in our course and curriculum now than it was 5 or 10 years ago, because it has to be, both, you know, because that's what you need to do to succeed and comply with sort of GMC as well.
And I would say, I think the capacity for lifelong learning, because as you say, so much changes, not only the core knowledge, but the whole playing field that you're on, and a desire to innovate. Because I kind of remember being at medical school and seeing it as like a fixed body of knowledge that I would learn and know, and then that would last me for 30 years, and that is so wrong.
Yeah, and actually I was talking to Josie before we started, and I was saying how I remember the first PBL case that I ever did, which was the gentleman with the ear hearing loss. And I do still feel a bit like that on those, there are certain PBL cases that I remember that I am still just like gradually adding and adding onto as I go along. So I agree with you, Mike.
And have we got any other questions from the audience? I just wanted to let everyone know I've also turned on the chat now. So if there's not time to address your question during this event, we can always take a look back and see if we can address them afterwards. So I'll just give everyone a couple of minutes. Or if Josie, you have any questions for Bryony or Michael, equally if Mike or Bryony, you've got any for Josie as well, please go ahead.
Well, I have a pitch that I was hoping to make. If anybody is interested in military medicine or finding out more, I'm actually in a military medical society, and we're hosting a conference on Thursday, the 21st of August at the Victory Services Club in London, which is a military club, but civilians are welcome. The evening before, there is a dinner, which would be free to undergraduates who may be interested in joining the military. And the conference is on lifestyle leadership in the digital age. So we're looking at, well, we've got quite a few interesting speakers lined up to talk about how we can shape and influence healthcare using technology. So I will send the link to Heather, but if anybody is interested, you can just drop me an email and I will tell you a little bit more about it. But very low pressure, very interesting, very fun. And I always found Georges to be very supportive of my sort of military interests, and I'm sure they would let you have some time off to do it if needed. So thank you, Heather.
Thanks. Thanks. And just to add, I can also add that to the post-event email for anyone who's interested. And if you're a student joining, please feel free to pass that around to your classmates as well. And I know that Bryony really kindly mentioned that if you wanted any other information on joining the military, you can also get in touch. So if you email the alumni email address, alumni@sgul.ac.uk, I can pass on any questions you have. Okay, so any other questions from the audience? Thank you, Hannah, as well. So Hannah has also mentioned that we could share details of that in our MBBS newsletter and virtual learning environment.
Thank you.
Jane's got a hand up.
Ah, yes, Jane.
Thanks very much. That was really fascinating, and it was really good having that interview approach, because it was very, very interesting questions and very interesting answers. My question's for Bryony, actually. It's about the territorial army and the degree to which what you do for people who are clinically minded or interested in healthcare, and whether there are sort of territorial arming opportunities for students and others to come and be involved, either in what you do or more generally in the RAMC?
Yeah, definitely. This conference is open to anybody. So sort of I think they're referred to as reservists now.
Reservists,
yeah, reservists. So they can come to the Hayward Club conference. I'm not really sure what other sort of thing were you meaning?
Well, I mean, actually, becoming a reservist.
Okay.
So, and being in, what opportunities there are to be involved clinically to different degrees. Yeah,
no, I think there were some people, because I know Josie did OTC, which is Officer Training Corps, which is run by the universities for students to go and I don't know, is it one evening a week and some weekends and do some sort of basic training. I think there were some graduates who were actually reservists as well as doing the medical degree. Because then they could get paid at the same time and maybe go away and do some exercises and things and do a bit more of that sort of pre-hospital medicine. And then there are doctors in the military who are reservists. So they will pretty much, I mean, the people so doctors in the army who are, say, surgeons or endocrinologists or ED doctors, they will spend pretty much their entire training and then their entire career working in the NHS. But if they're required to deploy anywhere, then they just get sent. So I think that's how it works for the reservists as well.
Thank you.
I hope that answered it. I'm sorry. I'm not really sure about the reservists that much.
That's fine. Thanks. Josie's got something to add.
My question's for Mike particularly. Having heard about your amazing experiences with Extreme Everest and your work with CASE, post-COVID, when things start to open up again, are you allowed to talk about any future research projects that you're thinking about doing? What's the next step for you?
So we haven't got any field projects at the moment, and that's partly because we spent most of the second half of the first decade, so 2007 onwards, and then a fair bit of the beginning of the next decade doing field projects, and we've just got a huge amount of data and samples, and we're probably all getting a bit older, and we're in fairly established research jobs. So we kind of made a resolution to ourselves not to go back to the field unless we'd properly delivered on all the stuff we'd already collected and done the linked translational research. But so I went to Nepal years before Extreme Everest. I've been going for about nearly 30 years, and we've taken the kids who are 12, 10, and 9 3 times, and they've had several birthdays there. And we were just about to go when COVID struck. So we were a few days away, and the airport's closed, and it clearly became a ridiculous thing to do. And we're really hoping that we'll manage to get a family holiday to Nepal next spring, if it's the right thing to do. I mean, it's difficult to know with COVID in Nepal whether that is the right thing to do. But we've got good friends in the country. But that's probably the nearest. We're hoping, on the basis of all the on-calls I did during COVID and my wife did, that we'll manage to get a month and go and do a proper trek just as a family.
That's lovely. Thank you.
Thank you. Any other questions from the audience? If you did want to have a think as well, please feel free, as I say, to email us afterwards. We can always pass those on to Mike or Bryony if you've got anything extra to add. So I think if there are no other questions, I'll hand over to Hannah Cock now. And thanks again for joining us, Hannah. Great,
thank you both. So huge thanks both to Dr. Bryony Hastings and Professor Mike Grocott for coming, for your really wise and insightful comments and reflections, and also to Josephina for her expert debut as a future talk show host, by the sounds of things. So I think the two stories we've heard, and actually Josephina's input as well, illustrates beautifully how our programmes, including our graduate programme, which is 21 years old now, which is terrifying, supports people with a breadth of experience to flourish and progress. And it's really great inspiration for our current students and aspirational students to hear and see people who've been where they are now, especially such shining examples of their potential future journeys. So huge thanks to both of you. I would say it's also enormously rewarding for the academics and clinicians and people like me involved in running a course like medicine to be reminded of what a privilege it is to be a small part of that journey, from student to doctor to future colleague, future leader, and to see the important contributions to society that our graduates go on to make. So I'm really delighted that you've joined us today, that you've stayed part of our community as alumni, and I hope we'll see you again at some other event in the future. Thank you all very, very much.
Oh,
Thank you very much.
thank you, and thank you, Josie.
Great job.
Really
It's been a pleasure to speak to you both, and thank you, Professor Cock, for also having me.
Thank you, Hannah, for speaking. Thank you again, Josie, for interviewing, and thank you, Mike and Bryony, for speaking. I think it was just so interesting to find out more about the different career paths that a degree at St George's can lead to, and it just shows the breadth of careers available to our current students. And I hope that's been really insightful for you as well, to find out a bit more from Mike and Bryony. I look forward to sharing more information on upcoming Alumni Perspectives events in the future. And as I say, we'll also be sharing more content, reflections, stories from our alumni on the Graduate Entry Medicine programme course. But we're always looking to share the stories of our alumni from across our course portfolio, and we're really proud of the achievements of them as well. So if you would like to get in touch and share your own experiences, please let me know. So I hope you've enjoyed that and found that interesting. Thank you again, everyone, for joining, and enjoy your afternoon.
Thank you, Heather.
Thank you.